Good afternoon. Thank you for joining us for today's webinar. This is Closing Gaps in Integrated Care, Brain Injury in the Complex Addictions and Mental Health Client. This webinar is sponsored by the Rural Veterans Health Access Program and provided by the Alaska AHEC Area Health Education Centers. All participants will be on mute during the presentation. If you wish to ask a question, you can type it into the question box at any time, and there will also be time for questions at the end. All questions will be held to the end of the presentation when our presenter will address them. If you would like a copy of today's presentation, you can download it from the Handouts tab in the sidebar. Now, we are joined today by Susan Maley, Program Director for the Rural Veterans Health Access Program, and our presenter, Dr. Carolyn Lemsky. I'd like to turn it over now to Susan Maley.
Thank you, Pat. And I'm happy to have Carolyn Lemsky presenting today. I first heard Carolyn present at the 2015 Alaska Brain Injury Network Institute, and she had a lot of information to share, and that was a limited participation event. So now we're able to share this information with the state. Our project is part of Health Planning Systems Development Section, the Division of Public Health. We're funded by the HRSA Office of Rural Health Policy, and our mandate is to provide telehealth and increased access to health care for veterans, their families, and other rural community members. And as part of that, we have worked with different specialists on aspects of traumatic brain injury. So our objective has been to deploy telehealth connectivity in Southeast Alaska rural communities, and as of next month, our next 3 years expands to statewide rural communities. So in addition to providing telehealth for counseling, we also have another focus, which is to provide training, and that increases access. And that is using telehealth technology for behavioral health and traumatic brain injury. That's one of our priorities for veterans and other rural community members. Pardon me. And veterans not only experience TBIs from their military service, but also in Alaska there's a high TBI rate after service because of ice and falls, etc. So this is part of our effort to provide training to community health providers, and we work closely with the VA, and I also want to mention that our questions that we ask at the end are evaluation questions about this event, but also there's a question there about whether your agency serves veterans and or their families. That's really important for us to know, and we appreciate you taking the time. There are just a few questions at the end. So this slide shows my contact details if you have any questions. The other thing it has is a link to our webpage, and all of the webinars that we do will be posted there. Currently, there's one there on assessing and treating mild traumatic brain injury, with the presenter being Dr. Amy Murphy, who's a certified brain injury specialist. So I want to welcome our presenter today, Dr. Carolyn Lemsky. Carolyn is a board-certified neuropsychologist with 25 years of experience working in rehabilitation settings in the U.S. and in Canada. For the last 15 years, she's been the clinical director of Community Head Injury Resource Services of Toronto. And that is an agency that is funded by the Ministry of Health and Long-Term Care, and it's designed to promote community reintegration of persons living with the effects of acquired brain injury. And Dr. Lemsky is working at a very important confluence of brain injuries and substance abuse, and for the last 9 years, she's been the director of the Substance Abuse Brain Injury Bridging Project. This is a research and knowledge transfer initiative and along with her partners at the Center for Addictions and Mental Health, she's trained over 2,000 mental health, addictions, and acquired injury providers in the basic skills that are needed to promote the development of more accessible addiction programming for people who are living with substance abuse and acquired brain injury. So I would like to welcome Dr. Linsky.
Thank you, Susan. So to get started today, I first of all want to say it's a great privilege to have the opportunity to speak to folks up in Alaska. We know that I'm here in Toronto, and I think that one of the real draws for me in learning more about Alaska is that we really have quite a lot in common. Here in Ontario, we have urban, rural, and remote communities, and I know that there are a lot of cultural links between our Indigenous populations, and so we face some of the same issues and some of the same challenges. Before I get started, though, I wanted to acknowledge our funder, the Ontario Neurotrauma Foundation, and we're going to be talking a little bit about some data that were collected with partners from the Center of Addiction and Mental Health here in Toronto and Reconnect Community Health Services. So what are we going to do today? Well, in this short hour on a Friday afternoon, we're going to be talking a little bit about the prevalence of brain injury in clients being served by mental health and addiction settings. And I'm hoping to go through this material quickly enough that we will have some time to discuss the unique application of these data to the Alaskan context. But I'm hoping to talk a little bit about the prevalence of brain injury in clients that are served in settings that you might be involved in providing services, understand how brain injury is related to complex care needs, and then hopefully have a little discussion about addressing service gaps, building awareness of the links between brain injury, mental health, and addictions, the importance of screening, although in a future webinar we may talk about the methods employed in screening for brain injury, and increasing accessibility to folks who may be living with some neurocognitive impairment. So I'm going to start out by asking a question, actually, and we're going to I see that the poll is open now. What percentage of the clients that you serve do you think have a history of acquired brain injury? And I understand from Susan that many of the folks who would be attending this webinar are working in addictions and mental health settings. So we'll give folks just a couple of seconds here to answer that poll. And when you think the answers have slowed down, Pat, you can show them. So I'm getting a message that says that the organizer must hide poll results to enable screen sharing.
Actually, we are showing it on the screen. Should be showing it on the screen right now.
Do I change presenter?
Carolyn, if you could just open up your box that says audience view, you should be able to see the results. Right now, our highest percentage is 37% say between 10 and 30%, 33% say between 30 and 50%, and so 20% are 5 to 10, 7% over 50%, and 3% are less than 5%. So well, a little bit across the board.
A little bit across the board, and I think it's what this suggests to me is that you're a pretty savvy audience. You know that a high percentage of your folks are presenting with issues related to acquired brain injury. And so when I talk about these statistics, you're going to be aware that brain injury is both a risk factor for substance use and mental health problems and is also often an outcome of substance use and mental health problems. So I'm going to probably wind up going through some of these statistics rather quickly so we can get through the meat of the discussion. Now, I think folks are probably aware that there's about 2.5 million ER visits that are related to acquired brain injury, but that misses a lot of folks. What's not represented in those statistics are people who are treated in outpatient settings, and also, very importantly for this webinar, military and VA patients are not represented here. But it does give you an indication of what the trend has been over time, and I think with awareness that concussion is an important health issue, we see an increase in ER visits, and with improvements in healthcare, we're also seeing a decline in the number of deaths that are associated with acquired brain injury. But again, this is sort of the tip of the iceberg when we think about the folks that we may be serving, because in the populations of folks in addictions and mental health settings, there's a greater likelihood of having serial concussions as a result of falls or abusive situations. I'm using this slide from the Department of Defense kind of as a nod to our VA link here, but also because these data are very similar to the data at large, which regarding the proportion of severity of injuries. Most injuries, the vast majority, roughly 75 to 85%, are mild injuries, and that's those that are associated with a brief loss of consciousness and no findings on MRI or imaging. Moderate to severe injuries, and they don't include complicated mild in this discussion, but make up about 15% in the general population, and the remainder are severe injuries. Now, I also wanted to call to your attention that probably about 15,000 injuries a year are not represented on those statistics that I showed you in the last slide. So what are the causes of TBI? I think this might also be familiar information for folks. Falls is by far the most frequent, but motor vehicle accidents and assaults and being struck by an object or falling against an object are also pretty popular causes. And then there's a group of about 20% that we just don't really know what the cause is. And very often those represented by folks with serial TBIs, again, from abusive situations where the cause isn't accurately reported. So one of the points that we would make when we look at the statistics is that many injuries are simply uncounted, and the current estimate is that about 1 of every 9 concussions across the nation aren't counted. And one of the points why that's relevant when we're looking at mental health and addiction services is that it could be that one of the groups of people that we should really be concerned about are those seeking mental health and addiction services, for the very reasons that I've been talking about. The likelihood of being in abusive situations where getting serial concussions might be a particular risk, or where a person's blacking out, falling, and hitting their head as a result of their substance use. Susan mentioned earlier that there is a high rate of TBI in Alaska, a little higher than the national average. And what also we need to think about is that there is some additional risk that seems to be associated with being from a native culture. And what we see is that in non-native populations, the rate of brain injury is actually a little bit below the U.S. average until you get to be 60 or 69 years old, and then you see that the hospitalizations that result from brain injuries increase. So what is this, what exactly do those things mean? I got these statistics from the Alaska Brain Injury Network, and I'm going to leave it into our discussion to determine what those statistics actually mean for integrating mental health and addiction services. But we do know that as many as 80% of people living with TBI meet the criteria for primary psychiatric diagnosis within 7 years post-injury, and that's people with all levels of severity of brain injury. Patients with TBI compared to age and sex-matched controls have more psychiatric illness both before and after brain injury. I'll give you a couple examples as we talk. And comorbidity is common. And this is just one example. About 50% of the depressed people with TBI also have generalized anxiety disorder. But as we move forward, you'll also see that it's fairly common comorbidity to have some psychiatric disability along with substance use disorders and brain injury. Now, in preparing for this webinar, I had a look at the trust, which is the Alaska Mental Health Trust Authority, and they put up the scorecard. And what you see on the scorecard, I won't go into too much detail, is that alcohol use in addition to brain injury is a little bit higher than the national average in Alaska. Alcohol mortality is much higher, heavy drinking is a bit higher, 54%, binge drinking 26%, and illicit drug use is about 35% higher than the U.S. base rates. An alcohol association by age of non-fatal hospitalizations in Alaska, and what this refers to is the number of people in each age group where their brain injury which required hospitalization was associated with alcohol. Now this could be an underestimate in part because it doesn't include the driver who may have been intoxicated or somebody else who was related to the accident. But what you see is this curve that indicates that young adults between the ages of 29 and 40 are really at highest risk for brain injuries that are associated with alcohol use, and of course that mirrors the age ranges that are associated with greater alcohol use. Now, I only bring up the prevalence slide here to say that traumatic brain injury of all ages is estimated to be, in most of the states, the estimate that you see most frequently is between 5 and 8% have had some brain injury of any severity in their lifetime, and the statistics that are coming forward here are look a little bit lower, while mental health and addictions statistics look perhaps a bit higher. And so what we think, when I look at these data, it suggests that there's probably some things that aren't being caught in those statistics, many brain injuries that aren't being caught. So I'm going to talk to you very briefly about two sets of screening data from the Center of Addiction and Mental Health and from Reconnect Community Health Services. And what the relevance to this discussion is we're looking at the incidence of brain injury in populations of folks who are seeking mental health and addictions care. Now, these are in an urban setting, but I think that they probably apply generally. So the way we conducted the screening was using the Ohio Valley Brain Injury Identification Method. That's a very thorough self-report interview, and it's known to be reliable and valid, and it was integrated into the assessment protocol at the Center for Addiction and Mental Health main site. So just under 4,000 folks were approached, about 3,300 were screened, and what we found was that about 25% had some possible brain injury, but what I'm showing you here is that about 24% had brain injury that could be verified, and 19% had one injury with loss of consciousness, and having a loss of consciousness suggests that the injury was severe enough that there might be some longer-term outcomes from it. And 5% had 2 or more brain injuries of loss of consciousness. And these are brain injuries of any severity. When we look at the lifetime substance use in years, and we looked at it according to whether or not a person had a brain injury with loss of consciousness, what you found is that there's an increase of years of substance use with more brain injury load. And when we refer to brain injury load in this context, we're talking about people with a number of brain injuries with loss of consciousness or more serious injuries. So for instance, with alcohol, on average, with no brain injuries with loss of consciousness, there might be 19 years of use, but with 2 or more brain injuries with loss of consciousness, that number increases to 22 years of substance use. And the effects are more dramatic when you look at something like lifetime DTs at the bottom of the slide, and in that case, you can see that the risk kind of quadruples for lifetime number of years for of lifetime DTs. So then if we look at mood symptoms and across a person's lifetime, the blue bar are the folks who have no brain injury, the red bar are the folks who have 1 brain injury with loss of consciousness, and the green bar are 2 or more. And what you see there is, and I think, I guess there was a suicide webinar last week, and it makes perfect sense. With almost all the data from a variety of different studies, but what we saw in our sample is that the risk for having had a suicide attempt increases significantly in those with 2 or more brain injuries when they're compared to those with no brain injuries. And remember, this is a group of people who are seeking addiction services. The amount of suicidal thinking is increased, the amount of anxiety is increased, and depression is also increased. And they're increased in a dose-dependent fashion. In other words, the more brain injuries with loss of consciousness, the more likely a person is to present with these symptoms in their lifetime. Other symptoms include violence, and of course that's significantly increased with 2 or more brain injuries, and difficulty with cognitive issues such as concentrating. Now, how does that relate to when, gaps in the service? Well, we tried to look at whether brain injury load had any impact on a person's success in navigating services, and one indication that we have of that at present, and our analyses are continuing, are how many previous episodes of care did a person have if they present with a history of acquired brain injury. And what we found is that particularly for alcohol treatment, the number of brain injuries with loss of consciousness did increase the likelihood of previous episodes of care. So if you had no brain injury with loss of consciousness, you were likely to report less than 1 previous episode of care. But if you had 1 brain injury with loss of consciousness, you were likely to report on average more than 1 episode of previous care for alcohol use disorders. And the average was nearly 2 previous episodes of care if you were 2 or more ABIs with loss of consciousness. Now, I didn't put standard deviations on here. I should note that all of these relationships are significant. But the central message is that with a greater brain injury load, the number of episodes of previous care increases. And it's interesting when you really pick apart the data to look at different categories of acquired brain injury. So if there's no brain injury or a brain injury but there's been no loss of consciousness, again, there's an average of less than 1 previous episode of care. But when you get into at least 1 brain injury with loss of consciousness or multiple brain injuries with loss of consciousness, you see that there's this dose-dependent relationship. The people who seem to have the highest risk for multiple previous episodes of care are those who have moderate brain injury rather than severe brain injury. And there's 2 possible explanations for this. One, and we think this is the most likely explanation, is that these are the folks whose brain injury symptoms are subtle. They may have problems with memory or behavior or planning and organization that cause them to miss appointments and to appear less cooperative and are more likely to be lost to care. Whereas those with more obvious impairments or severe brain injuries are more likely to have case management services and other folks around to be helpful and are more obviously in need of accommodation. So we feel that that group with moderate brain injury load, those are the folks who are most likely to fly under the radar and are most likely to be in need of, but not get, specialized services. So we also conducted some screening of a similar kind in mental health setting. And in this case, we looked at all of the current and new clients from a community-based service provider, and we looked at all programs, whether they were coming in for mental health programming or whether they were coming in for ACT programming, which is assertive community treatment programs. And what we found was, of the 254 that we approached, 145 said that they had had a TBI. But history of trauma, trauma of any kind, was also pretty common in that group. 11 of the folks we approached had no TBI, but they had had a history of trauma. 94 had no history of trauma, no TBI and no history of trauma. So that's about 57% are reporting some TBI. When we looked at whether they were, some people will get a bump on the head, and that's not really likely a brain injury, but when they had some post-concussive symptoms, that's a possible brain injury. Of the people who reported that brain injuries in that group, 48 had possible, 62 had mild, 15 had moderate, and 7% had severe. So that's 60%. Who had a brain injury with loss of consciousness and a brain injury that was severe enough that you might expect that there might be some long-term consequences. So when we look at statistics from other studies, about 20% of people seeking services for addiction have had a brain injury with loss of consciousness. 25 to 50% of all people who seek treatment for mental health issues have a history of brain injury. About 15% of those have moderate to severe brain injuries. And then, and I won't go into a great deal of detail about this, but there's a high prevalence among marginalized populations, including homeless and in prisons. This was a very interesting study. I only include this slide to indicate that there is evidence that simply having a history of acquired brain injury does increase the risk for developing mental illness later on. And surprisingly, this is true for schizophrenia. In this Danish study, which is a population-wide study, and it was prospective, so they watched people over time, if you had a brain injury at any point in your life, you were at a 65% greater risk of developing schizophrenia following that brain injury. The same was true for depression, 59% increase in risk. Bipolar disorder, somewhat less, 28% increase. But you were at about a 340% increase of developing any organic mental disorder, which includes either cognitive impairment related to a brain injury or later on dementing illnesses. And there's a lot of evidence from both American and Canadian studies. What I have here is an example of a Canadian study that even with concussions like sports-related concussions, when they're suffered in adolescents and children, they do seem to increase the likelihood of psychological distress, 52% increased risk. And there it is again, attempting suicide. There's a 239% increased risk, even with mild brain injuries sustained in childhood and adolescence. And then there's also a greater increase of requiring and receiving treatment for anxiety and depression. Inmates, this is also probably not new information, but varied estimates, but depending on the methodology used, but probably about 40 to 50% of all inmates report having experienced a brain injury or TBI as compared to 8.5% in the general population. And those prisoners, like the people who are presenting to addictions and mental health programs, those are the people who are presenting with loads of comorbidities. So they have more depression, anxiety, more substance use disorders, more difficulty in controlling their anger, more suicidal thoughts or attempts. Similar situation for ABI and homelessness. There's a lifetime incidence of 53% of any injury, 12% moderate to severe injury, and 70% seem to be injured prior to becoming homeless. So homelessness does seem to be a risk that arises from having had a brain injury. And this has been studied specifically in veterans populations, and the interaction between PTSD, brain injury, and substance use disorders do seem to create that increased risk for for homelessness. And of course, in those folks who reported brain injury among the homeless population, they also had a greater likelihood of having seizures, mental health problems, drug problems, poor physical health status, and poor mental health status. So when we think about these data, we can see that TBI history is prevalent among the users of addictions and mental health services, also among marginalized populations, and that brain injury is a risk factor for the development of mental health and addictions as well as the possible result of these issues, so causality is bidirectional there. And people reporting TBI history also present with greater complex comorbidity. So having a brain injury is sort of like an index or a warning sign that that person that you're working with is more likely to have complex issues. And a history of brain injury may be associated with invisible disability that requires specialized care. But unless you ask the right questions, you may not be identifying those individuals who require that care. Now, in addition to cognitive problems, TBI seems to be associated with emotional dysregulation. And that's because a brain that has to work harder tires quicker and is less resilient. And it's known outcome of acquired brain injury that there's damage to the blood-brain barrier. And briefly, the blood-brain barrier is a set of mechanisms in the blood vessels in the brain to keep the circulation of the brain separate from the rest of the body. And so when that's damaged, any intoxicants or toxic factors or even just low blood sugar that happens in the rest of the body now has more influence on the functioning of the brain. And so it may be that even when there isn't frank cognitive impairment, emotional dysregulation may result from traumatic brain injury. We also know that TBI as a cognitive factor makes it difficult for a person to actually read social cues, particularly facial expression has been studied quite a bit. But the difficulty in reading others' facial expressions and emotional nonverbal cues really does create a lot of interaction and social difficulties. And of course, for example, in the homeless population, this creates special burden because you're living in group situations and more conflict is likely to occur. And these difficulties are subtle, and unless they're specifically evaluated, they may not be understood as a part of the problems that are presenting for individuals. Another really important thing is that in acquired brain injury and TBI, there's a high incidence of the reduced capacity to respond normally to rewards and punishments. So folks have a tendency to be more impulsive. They have difficulty in delaying gratification when there's the possibility of a short-term reward in the service of a longer-term reward. And as a result, their behavior often fails to be productive. And also TBI may interact with brain changes related to substance use or medication use. So medications may have a different impact on people with acquired brain injury, and we know that things like seizure risk increases with some agents, for instance, antidepressant medications. And so it's important to understand or to know about brain injury history in these groups to provide the right care. So what's the impact of brain injury on service? Accessing service. It's often pretty subtle. The signs can include particular difficulties with remembering appointments, paying attention and tolerating group situations. Remember, if we're talking about a person who's having trouble reading social cues, it's going to be hard for them to participate in any intervention that's offered in a group setting. If they have trouble with memory, they may not retain the information that's being offered in those addiction settings. And social skills and reading cues, of course, presents a huge difficulty. So these patients with a history of acquired brain injury tend to present with a larger gap between what they say and what they do. And it's a very common problem in the folks that we serve that a person will come in with apparently good insight and apparently high motivation, but then fail to follow through with the expectations of service. And this seems to be an even more sort of puzzling gap between say and do than in the general population of folks that are being treated with substance use disorders or mental health problems. And along with all of the complications that come with acquired brain injury, they're more likely to have a chaotic lifestyle and relationships, and they're more likely to have problems with problem solving that cause them to just simply appear to be rigid in their thinking or stubborn. So I'm going to allow you to respond to this poll. Were you surprised by the findings that I reviewed? I'm going to venture a guess that many of you were not, because your initial poll suggested that you were pretty well aware of the high prevalence of brain injury and addictions and mental health. It's probably about 1 in 4 or 5 of the individuals that you're seeing that have a significant impact of an acquired brain injury in their history. So I guess we can look at the results of the poll.
Okay. And Carolyn, what we have is 12% of our participants were surprised and 88% were not.
Yep, so this is a pretty savvy group. The next question we have is, do you feel that you have the needed tools to effectively treat this complex group of clients? So do we have the results of that poll?
We are getting close here. One moment. We'll give everybody one more chance. There we go. And what we have is only 3% have the tools that they need. 63% do not, and 35% really aren't sure.
Okay, so I'm saddened to hear that, because we'd like you to have the tools that you need. I think we're going to be doing some more practical, more skill-based webinars in the future as a part of this project to talk about screening and actual skills that frontline workers may be needing to integrate care. And today we're going to go on and talk a little bit more about the elements of integrated care and what we need to do. Now, we know that the service gap is that people with a brain injury often go unidentified. So if you're not screening for brain injury, you don't know that some of these folks with really subtle impairments are in the population that you're serving, and some of the problems that you're experiencing in serving them may be related directly to neurological impairment. Once they are identified, they may have a difficulty identifying services. I know that in the Canadian context sometimes there's a bit of stigma going back and forth. So somebody who has a severe brain injury may not be readily accepted into addictions and mental health services, thinking that brain injury providers may be better suited to handle their difficulties. But as we know, brain injury programs may not have all of the tools that they need to manage addictions and mental health issues. So there really can be a catch-22. And there are limited models of integrated care, and in some cases very limited resources. And again, these are the clients that seem to be the most complex, and they wind up in the judicial system. Homelessness is a very big issue for them, and of course they often wind up incarcerated. So how do we close the gap? We have to identify those with brain injury history, systematically evaluate what happens in the current systems and model of care to see if there's any adaptations that we can make that that improve intervention and increase system capacity to implement the structures. Okay, so that's a long-term project that has to happen system-wide in what we're undertaking in Ontario. And the first step of that is actually getting programs to screen for brain injury and raising awareness of the issue. One of the things that I would point out is that mental health and addictions providers, although that system is often under stress and often considered quite underfunded, are generally present in more communities and in greater numbers and with more capacity than brain injury specific services. And hopefully, and I do intend to save some time to talk about this, my understanding is that situation is very similar in Alaska. And so it won't do to say we're going to identify these people and refer them to brain injury specific services. We really have to look at the elephant and the mouse cooperating. So the more resource service becoming more brain injury aware and having a better sense for how to serve those folks within their existing resources. So we have to be motivated to integrate the care and to avoid sort of treatment silos. Now, the factors that affect treatment recommendations include the relative severity of brain injury and the substance use disorder. The other factor is the client's current readiness to participate in treatment. And the final factor is how well aware the individual is of the disabilities associated with their brain injury. So all of these factors will affect how the individual is served. This Muser model may be fairly familiar to folks, and the idea here is that in an ideal world where there is integrated care and each community that you work in is equally resourced, that a person will get care depending on the relative severity of the problems that they're presenting with when there are two or more problems presenting together. And so in this case, if we're looking at, for example, brain injury and substance use, if the brain injury is relatively severe, but the substance use is relatively mild, right, then they're going to be served in an ABI-based intervention where they're going to do screening and treatment and shared care for that brain injury. If the brain injury is mild and the substance use is mild, they're going to handle that in the ER with a brief intervention. But what do we do when the severity of the brain injury is significant and the substance use severity is significant? At that point, you really need some specialized integrated care, and that is the recommendation, but in many communities, that doesn't really exist yet. The other thing is that many addictions programs are not kitted out to deal with the problems that come with serving somebody who has cognitive and behavioral issues associated with acquired brain injury, and likewise, brain injury programs aren't all kitted out to manage addictions and mental health problems, so we really need that cross-training. And what we find from the literature is that the best practice really is intervention that's integrated, dual or multiple primary treatment in which each condition or issue receives appropriately matched intervention at the same time. So that means that if you've got somebody in your program who has problems with managing their behavior as a result of their brain injury, you have to address that while you're addressing the problem with the addiction or other mental health issues. And that can be kind of a daunting prospect. So what actually is integrated care? Well, all the client's issues are managed together in a single coherent plan. So cognitive and mental health and social features of the client's presentation are considered together. And the plan features the needs and most pressing concerns of the client and the family. Consideration is given to the healthcare perspectives, but it's really the client and family that are dictating what the priorities in treatment should be, and recommendations and plans are made in consideration of the client's actual situation and the current resources available. But that's a standard that sometimes can't be met with available resources. Because when we think about it, what are we integrating? Okay. Now, when we're looking at somebody who has a brain injury and likely has both mental health and addictions comorbidities, so we have three things going on, we're trying to integrate care related to those three diagnoses. But we're also integrating care across sectors. So we're integrating care across the healthcare sector, looking at inpatient, outpatient, and community integration, and we're also looking at integrating care with housing providers, transportation providers, and very often justice. And so integrated care becomes more complicated. Now, what I've noticed in working with both rural and remote communities is that there are fewer providers, and that becomes an advantage in some sense in providing integrated care because there isn't an isolated brain injury provider. All the buck stops with very few providers and they provide everything. The trouble then becomes in those situations the resources to do everything you would like to do for an individual. So if we talk about the development of integrated care over the course of our service revisions here in Ontario, we have to think about it from a funding perspective, an administrative perspective, organizational, service delivery, and clinical. All of those are needed. And I've got referenced here what I think is a really good paper discussing the what the nuts and bolts of actually creating a setting that has integrated care really consists of. Now, in the Alaskan context, and again, I'm going to try and save some time for comments, so I should really be wrapping up my comments actually at this point. We're looking at funding for mental health, addictions, that's coming down the pike, and we're also looking at the TABI or individualized waivers and how those can be used together to address an individual's needs. Organizationally, the co-location of services, you've got to be in close proximity. There have to be discharge and transfer agreements so that when a person's leaving a service, the other service can pick them up in an integrated fashion. Interagency planning and budgeting. I think very often in Canada, and I would appreciate the comments from the Alaskan perspective, one sector may get funding and there may not always be sort of the cooperation to plan across diagnostic groups. And that's important if you're ever going to develop jointly managed programs or services. What is more easily accomplished because frontline providers see the value of cooperation are strategic alliances, but when it comes to the level of care networks, you really need to have administration and funding online. And consolidation and common ownership or merger is one way, so having a bunch of agencies under a single umbrella, but that often isn't palatable to community-based agencies. So, what do we do for service delivery? We have to be training addictions and mental health and brain injury providers all together. They have to be using centralized information referral and intake. Case care and case management needs to be done using similar models, and multidisciplinary and interdisciplinary teamwork has to function together. We would like to have around-the-clock on-call coverage. Again, that's an ideal that's to be worked for, and integrated information systems. So all these things are the ideals of integrated care. Administratively, you have to be able to consolidate or decentralize responsibilities or functions. So, there has to be planning between sectors. So if you have the possibility of participating in planning for brain injury services if you're in the mental health sector, that's something to be doing. Doing needs assessments and allocating, and joint purchasing and commissioning. For clinical integration, you have to be using the same language, and I noticed that in brain injury and addiction setting, brain injury rehabilitation settings, they tend to use a different diagnostic terminology for similar issues than mental health and addictions. And they also use very different assessment procedures. They have different care planning models. So those things really have to be integrated so that the interventions that are being used can be offered in a coherent fashion. Now, brain injury services can screen, educate, and provide brief intervention and referral when it comes to addictions and mental health problems. Addictions and mental health based care needs to be able to provide harm reduction treatment and active partnerships for consultation and referral when they encounter folks with these complex mental health and addictions issues. And then the specialized service has to be, and in Ontario it's developing that as a result of service-related partnerships, you're actually able to provide care that considers both mental health and addictions and the cognitive and behavioral issues related to brain injury. So what does that look like? You get up front and cozy with the folks that are providing addiction services if you're a brain injury provider, and you offer to provide brain injury supports while the individual is in the addictions treatment program, and providing training, that cross-training, such as we're doing now, to make people aware of the issues so that providers in both service sectors are using the same language. In brain injury services, there should be an addictions counselor who is providing direct support. And in mental health sectors, there should be long-term supports for people who have neurocognitive impairments. So the elements of capacity building include screening for acquired brain injury, recognizing and compensating for cognitive problems, and then looking at service models that rather than relying on an individual to develop improved self-management, so we give somebody the skills that they need to manage triggers or manage their emotional state and hope that they're going to be able to manage those on an independent basis, start looking at and focusing more on models like community reinforcement approach that put more responsibility on developing environments that promote the behavior and reinforce the behavior that is more productive for the individual, and have less reliance on these models that require independent self-management. So what do you do now? Well, I'm wondering how many people screen folks for acquired brain injury and mental health and addiction services, and how many service providers actually track clients, whether they come back for assessments, whether they're attending the program, and what they're completing. So based on what I've said, what are the challenges to implementing capacity building? And in this case, we're going to ask you to say, you know, is it budgeting, available partners, expertise in training, or something else? And as those results in, you can pop those up when you feel like they've slowed down a bit.
We've got just a couple of, maybe just another couple of seconds to give some other people a chance. If you also had an other, you're welcome to type in what your other is into the question box, and I'll be happy to read them out. Okay.
Oh, thanks for that reminder.
Okay. Let's go ahead, and we will go ahead, and we've got about 80% have answered, so let's close that out, and we're going to try this again to see if we can let everyone take a look at it. Are you able to read that?
Okay, so yeah, so it seems as though there's an equal division between budget and available partners, and that accounts for just a bit under a half. But the biggest gap is in training.
Okay.
And having the kind of training that actually results in skill building for frontline providers. And so that's really something that can be addressed in the short term, and those other sort of systemic issues will hopefully be addressed over the long term as we gather data so that we can demonstrate the need to do that.
And we do have a couple of others. We sure did.
Okay.
We have one, scope of work now being performed. A second one is high staff turnover and lack of follow-up. We had several comments on the states doesn't have a TBI waiver, and then we have budgeting is always a factor, but here another challenge is creating cross-sectional partnerships between public, the SUD treatment, and private, the TBI expertise.
Ah, okay, so it's a public-private issue in us, and that's really good to know. I'm taking notes about that because as we move forward with the other training, I think we have to have a model that fits in with a private provider providing those supports to a public provider, and what the issues involved in that might be. It's a very important point.
Okay, and that appears to be it for our others.
Okay. Well, so thank you for that participation. That makes everything a lot more meaningful. I mean, here in Ontario, we know that services that aren't designed to manage complex co-occurring disorders, it sounds like that's a little bit similar where you're at, and you need two providers involved, and that's particularly true if you've got that public versus private split between ABI and addictions providers and mental health providers. Stigma is an issue. We've had to do some training with addictions providers to desensitize folks to the risks. They were very concerned about having people with brain injury in their programs, and the same precise risks were concerns for people in the brain injury program when they were talking about working with people who were actively using substances. And so a part of the training really needs to be addressing those professional stigma even among professionals. Big one, and you've identified this also in the poll, lack of knowledge and information, and again, we hope that the webinar, the couple of webinars that we're going to do are going to address some of that. One of the other comments that came out in the other barriers to care is the number of things I already have to do. And a lot of service providers are finding themselves really pretty stretched thin, and you wind up having to be, especially in rural services, kind of a jack of all trades. So whatever models of care are adopted for these complex folks, they really need to be pretty straightforward so that they're practical for implementation in settings where people are really stretched pretty thin and have limited resources, and where the turnover of staff makes retraining a necessity. It really is hard to achieve continuity of care unless you have those ongoing resources. A single one-time training, and we understand this from our context, will not cut it. You really need to have that regular training and consultation. I'm going to end my comments here. I apologize if I haven't gotten to all my slides, but the meat of it really has been addressed, and I do want to leave at least a few minutes for if there's any questions. But Corrigan, John Corrigan, who's been a colleague of mine, who's out of Ohio, has talked a little bit about the 8 principles for integrated treatment. And we've talked about most of them being, interwoven and holistic and consumer and clinician, consumer focused with clinician collaboration. And developing the optimism for recovery. I think one of the really important things related here is that different services will be helpful at different points in the recovery and staging, and so we need case management models that stage folks according to their capacity and their interest in care, and that we're flexible in our service delivery so people can get in and out of services when they require. The treatment is definitely longer term, so when we identify brain injury, this is a person who's going to need longer term care than what some of our programs might have as deadlines, and that's or typical courses of care, and that's certainly an administrative issue that needs to be dealt with. What we have done is we've taken staff who are more stable and who are key, and they are cross-trained, and we give them smaller workloads. And what that does is it increases continuity of care, and that's something that Corrigan also identified, and that staff who are more experienced and have should be the folks that are cross-trained. So I'm going to end my formal remarks there and ask if there are any questions for the few minutes that we have remaining.
And we had one very early question, really almost before we started. Is a stroke in the brain considered a brain injury?
It is. It's an acquired brain injury. Okay. And what we find is that, especially working with addictions and mental health providers, is that sometimes substance use of different kinds can increase the risk for stroke. And so we often see stroke, young stroke, early stroke in the population that we serve in our integrated care.
Okay. I have a comment here. Please speak more to case management care coordination models that could be helpful.
Okay, so in a future training we're going to talk a little bit about how staging a person in terms of their stage of change is very important in case management. And we think of a phased approach to care where we're doing less intensive, perhaps, but more outreach services for an individual who's perhaps not ready to change, and we look at that as the engagement phase. And it's very important, especially with folks with brain injury or complex needs, that we're flexible in how long that engagement phase can be and the kinds of services that can be offered in that engagement phase. After a person is well engaged and they're showing some trust in the system, then we start to look at actually addressing issues. And you have to be looking at where they are in terms of their stage of change related to if it's a substance use issue, but also how much insight they have into either their brain injury issues or their mental health issues. I think one of the things that often happens is that we try to focus people very quickly and they become lost to care because they're not ready yet to take advantage of the services that they're being offered. So again, that and in the model that we use, we call it persuasion. In that persuasion phase, we're working very slowly and gently with an individual using client-centered kind of an approach to design interventions that they feel ready for and they're willing to participate in. And it's not until they get into an active phase of care where we start to do those referrals to programs that would require their participation more specifically. And all along the way, we're continually thinking about how well the individual is engaged in the intervention that we're presenting. And you'll notice that that sounds a lot like motivational interviewing, and in fact it is. The other two models of care, if you were to kind of go away and Google, that are really, I think, important for this group is the community reinforcement approach, developed, and of course, because it's Friday afternoon, now it's 5 o'clock my time, and I'm blanking on the name, but out of New Mexico, the community reinforcement approach is a very useful approach in this group. Interventions that rely on reinforcement for participation. So incentive programs are really very helpful. And for families, community reinforcement and family training, which is kind of an offshoot of the CRA model, I think are very, very useful models. And so those are the things that we're sort of investing in, both in terms of training and in terms of research.
We actually have 2 more questions, but we are after 1 o'clock. If you would like, I can, actually 3 more. I could send them over to you to respond, or if you'd like to take a moment today.
I don't mind taking a moment today if it's okay to go over a couple of minutes, but I can also respond by email. What do you think would be?
We will go ahead and give it just another moment or 2. You're welcome, if you are on the line, you're welcome to please hang on the line with us. We might have some good questions to provide you some good information, but we will just take maybe another 5 minutes.
Okay, and I don't want to interfere with the follow-up questions because you've got to.
No problem.
Do those happen?
The actual, if you do happen to sign off, you will have an email, a launch of a survey that'll happen automatically when you sign off. And when that happens, please make sure that you complete that. That's very important for us to know that we are making the training valuable to your service and your care. There is also a question in there about whether you provide care to veterans, which is valuable to our sponsors, our Rural Veterans Health Access Program. Let's go ahead with another question or 2, and what we have is a question: do you have any suggestions for resources for patients to help themselves as they wait for agencies to implement these long-term solutions?
Okay, so if we're looking at brain injury and addictions and mental health, I'll direct you to our website, www.subi.ca. We have a workbook that's designed for clients. There's a lot of useful client-oriented information on another website, www.brainline.org. And that will connect you to both our website and some of the work that's been done in Ohio Valley. There's a few videos on there, and it provides a lot of information about coping both with brain injury and with substance use after brain injury, as well as mental health problems. So those, I think, are very valuable online resources.
Okay. And our last question, which actually the last 2 were combined, what provider gaps do we have? Do we need more LCSWs, psychiatrists, PhDs, PAs in psychiatry, psych NPs, neuropsychologists, patient advocates, or case managers?
Well, you know, if I map this onto my system, and I only had that one brief visit in Alaska, so I can't really speak to that, but I can tell you that in our rural system, there's mind you, I'm a neuropsychologist, so I don't want this to sound too self-serving, but there's an absolute lack of neuropsychological services. And while I don't think everybody needs a full neuropsych battery, I think it's some way of getting cognitive testing done with folks, not for the purpose, well, it helps with diagnosis, but the main purpose of that is helping them to understand what they are facing and helping them to develop the right compensatory strategies. And when I do consultation remotely to a couple of rural communities, and what we are constantly trying to figure out is how do we provide that service so that both service providers and the clients themselves can learn to compensate better. I know that's a gap in service. The other thing too is that the most effective treatment tends to be that which is frontline, and so access to psychiatry services and neuropsych services and neuropsychiatry services is very, very important. Primary health care is also often in short supply, and I know that nurse practitioners are very highly valued in our rural setting. But the front line, there's no substitute for having that case management, having somebody to come to your door and help you get to your appointment, because many of our clients who are living with brain injuries simply need that support, particularly early on before they're not compensated for their problems, or they just never get care.
Okay.
So that would be my off-the-cuff.
Well, I really do appreciate your staying over for a couple of minutes to answer those two final questions for us, and that appears to be everything that we do have. So we want to thank you, Dr. Lemsky and Susan Maley, for your presentations today, and all of you for attending today's event. If you happen to think of any additional questions, or there are ones we were not able to address today, you can send them to the Alaska AHEC at UAA_AHEC@uaa.alaska.edu, and we will forward them on to Dr. Lemsky. Now, your certificates for contact hours will be sent in a follow-up email to all participants early next week. If you are viewing as a group, please make sure to email us for a sign-in sheet or just as to who was attending with you so that we can make sure you each receive credit. Now, to help us provide the best training, don't forget to take a moment to complete the evaluation that will appear as soon as the webinar ends. And again, thank you, Dr. Lemsky, especially for staying over a couple of minutes. This webinar is now over, and you may all disconnect. Thank you very much.
Thank you very much.
Thank you.
All right, thanks a lot. I guess I'm disconnecting from you too, right?
Yes, thank you.
All right, take care.
Bye-bye.
Bye-bye.